Hi, everyone. Good evening, and thank you for joining NATF's Ask the Expert. Our expert this evening is Dr. Scott Kaatz, who is a hospitalist at Henry Ford Health Center and a professor of medicine at Wayne State. He is also president of the AC Forum, which is another great organization in this space. And most recently, he is a COVID survivor. And I don't know if you remember this, Dr. Kaatz, but last time we saw each other in person was in December at the Dearborn Inn. We sat at the bar and had a drink with some colleagues.
Yes.
And I don't think any of us had any idea what the future held at that point.
No, we did not.
Yeah. So I know we were talking about travel plans for this summer and all that. So things have definitely changed. And I know you in particular have been really impacted by COVID, and I would love for you to share your story with the audience. I know we've gotten a few questions, so if you wanted to tell us more about that.
Sure. Well, thanks, Catherine, and good evening, everyone. So, there are so many struggles with COVID. I mean, what it's done to the economy, to the politics, to the unemployment, to the financial ruin, to the medical devastation and stuff. So I'm going to share you just our family's story for a minute, because at the end of the day, that's what gets a lot of us. And let me just say to start with, is that I feel very, very lucky, because I've had a dramatic and complete and rapid recovery. I didn't get any of the side effects of this from myself. For my family, what they went through, and then I'll tell you a little bit. And then I have also, I'll tell you, as a son, unfortunately, my father and I were on ventilators at the same time, a floor apart at Henry Ford. And unfortunately, we lost Dad to this horrible disease. So let me tell you my story to start. We'll just go about 5 minutes or so.
Sure.
So first thing is I'm a physician. I work exclusively in the hospital. I take care of adult patients. In early March, we started the surge in Detroit, and we surged dramatically. We went from a couple of cases in our hospital one day. By the end of the week, we had hundreds of cases.
Wow.
We literally filled our hospital with only COVID patients. More than 90% of all the beds, not only in our hospital, but in the city of Detroit, were COVID patients. So we got real sick, real fast, real dramatic, sort of what we're seeing in Arizona and Florida, and kind of what New York went through at the beginning of this crisis.
Did they link that to anything in particular? Like, I know in Boston, they linked it to a Biogen meeting, the big outbreak. Was there anything in particular in Detroit that they could pinpoint as kind of the start for this?
I don't think so. We didn't have any nidus, but remember, this was probably now 4 or 5 weeks after New York, and it's really been interesting to watch how the virus has spread west.
Mm-hmm.
Keeps moving west. Started in China, then we had Europe before we did, then we had the East Coast, and now we have the West Coast. The virus has been moving west, and we were in the Midwest, so we fell in between the two coasts on when they sort of got this. So, and then what we did is that we converted most of our floors to COVID floors, and I was seeing and staffing one of those COVID floors with a bunch of residents and obviously nurses and support staff. And so I did that for about 10, 11 days. And then I woke up one morning at 6 o'clock to get ready to go to work, and I knew I was sick. Of course, you can't go to work when you're sick, because I figured I likely had COVID, which I did. And then I spent the next week at home sick. So let me tell you that, because that's what in the medical community, we tend to say mild disease or moderate disease. You say that when you're not in the hospital and you don't require oxygen. And my guess is there's some folks in the audience that have had this, but there isn't anything mild, at least what I had with this. This was, you take your worst flu and make it a lot, much more dramatic than that. We sometimes talk about body aches. I call these body hurts. It was dramatic. Couldn't eat, couldn't do anything. By the end of the week, had a hard time getting off the couch, actually. But I was fortunate enough to have a very good relationship with my primary care doctor. Now, I don't want to say I got VIP treatment, but it just happens that my primary care doctor is also a colleague, also a neighbor, also a social friend. So I was in a really good spot. And I kept watching my oxygen saturations because I knew what this disease did because I had taken care of 40, 50 patients with it already. So I sort of had the inside knowledge. And then when my oxygen saturation went down, then I went to the hospital. Spent a day on a floor, a day in the ICU, a half a day back on the floor, and then a day in the intensive care unit. And I continued to get worse for 4 or 5 days. And then I went on mechanical ventilation. So I was on the breathing machine. And it was really fascinating when I did that because people said, "Oh, weren't you scared?" And I was more disappointed because I knew at that time what the rate of death was. So at that time, and it's still, you can probably use this as a rough number, is that if you get COVID, there's about a 5% risk of dying once you get the disease. Now, that's a little less as we see more testing and we see more young folks that don't die, and we've talked about in the last couple of weeks is mortality. But back then, when testing was more limited to symptomatic patients, about a 5% chance of dying. Once you get into the hospital, it's about a 15% chance. So 1 in 6 patients are dying. So one of the things that the healthcare providers and the hospitals are doing is that all of a sudden we had this massive amount of death, much more than most nurses, physicians, respiratory therapists, nursing aides see. And then once you get on the ventilator, about half of those patients die. So when I kept ramping up and kept getting more concerned and more disappointed because I wasn't recovering, I kept getting worse. And then for the next 3 or 4 days, I was completely unconscious on the ventilator, but my family went through a whole bunch because as I've learned now, because I was, as I tell everybody, I wasn't doing anything. I was just taking a nap on the ventilator. I was easy, but apparently I was about as close to it as you can get. Wow. And then woke up on the ventilator. As soon as I woke up, I was back to normal. I was good. A couple of days later, we pulled the tube, and I'm good to go. And then why we're a little bit about talking about this on NATF is because what I also have is I have an interest in anticoagulation, and I have an interest, a research interest in some career expertise and blood clots in the legs and the lungs. And then when we pulled out one of my big IVs that's in the net that you have to do many times for sick patients on a ventilator, as soon as we pulled that, we wiggled a clot loose, and I got a blood clot that broke off and went to my lungs. So for what Dr. Goldhaber set up with this organization and these sort of calls to be supportive of patients, I've had the disease now. I felt it, so I'm in the club now as well, part of this. And in fact, I will just finish up my blood thinners. Actually, I think tomorrow will be my last dose, and will be my 3-month course for blood thinners. So I'll tell you I don't know if it's cute because the outcome was bad, but as soon as I woke up and I was awake on the ventilator, and it many times takes another day or 2 to get patients off the ventilator, not just for COVID, but for other reasons when sick with an infection. What I was doing is I was trying to ask how my father was doing, because you can't speak because you have a tube in your mouth. And the ICU nurses were nice enough to let me use their personal phone to FaceTime my family. They would put it in a clean baggie so they could disinfect the baggie so they could share it then with another one of their patients. And so I'm doing that, and his name is Dick. Like, didn't know how to hold a phone and make a D, but I could try to do this, holding the phone. So it took my family a while to say that wasn't a 1, that was an I. And then I could make the C. I'm spelling. So my son and my wife are on FaceTime with me, and I get the IC, and they go, "Yes, Dad, you're in the ICU, the intensive care unit." And oh, bad. So finally, they figured out I was how my dad was doing fairly well at that time. So that was some relief for a while. And then once I got home, it was about a week after I got home, then we had the really bad phone call that he had to go back on the ventilator again, his fourth time. And then we withdrew life support several days later. But fortunately, with all my siblings at his bedside, so he died with his kids holding his. So anyways, that's my story. I think what we'll probably concentrate on a little bit is on the clot stuff, just because this is what this organization is about. And Catherine, I'm happy to field some questions that you're getting and that you got prior to this call, and I think you're getting sent in now.
Yeah, so thank you so much for sharing, and I'm so sorry to hear about your dad. This has been such a tragic time for so many people. I'm curious, going through something like this, you're in the hospital, you feel yourself getting worse. Is being a healthcare provider helpful at that point? Is it more alarming because like, I guess, did you look at that as a plus or a minus at that point, your wealth of knowledge?
Oh, for me personally, I looked at it as an absolute plus, because people were saying, "Weren't you scared?" And I was never scared. I was very worried and scared for my family. In fact, another story, just before I got put on the ventilator, we had with FaceTime with my two kids and my wife, we had the goodbye phone call, because I knew that there was a 50-50 chance that I wasn't going to live for the next, within 2 weeks, there was a 50-50 chance that I was going to die. So we went through that, and then I can remember my son is a little more interested in finances than my daughter. So I told my son, I said, get a pencil, a piece of paper. Okay. Here's where the file is with the retirement funds. Here's where it is with the bank account. And I can remember doing this. And here's the password. And it was 1, 2, 3. Get my breath, because I could not breathe then. And we went through that. So I guess from that standpoint, I knew how to plan this, so it wasn't a shock and a surprise to me. And then the other thing is because I'm working at a hospital that I've been at for 30 years, is I had colleagues, friends, folks I had trained that were taking care of me and coming up and just giving me the straight information so we could pass that along to family. And they were incredibly informative to my wife, who's a retired nurse, so she could process that also.
Wow. So you seem to have made a miraculous recovery. I mean, like you said, you really haven't had a lot of, the lasting side effects that other people do. I'm curious, what types of, long-term recovery issues are you seeing in patients with COVID and in particular with blood clots?
Yeah, so remember, so everybody on the audience, Catherine and I were talking just before we got started, and we said the usual answer to a COVID question is, we don't know. When are we going to start schools? When is the economy going to recover, et cetera, and we don't know this either. What we are seeing, at least short term, because we're only 6.5 months into this just over a half a year into this virus. So I think the big issue is we'll have to see what happens with, we'll talk about the lungs first, because that's where a lot of the action of COVID is, but not exclusively. And one of the things, and what happened to my father, is that if you're on a ventilator for a very long time, I'm not an intensive care unit doctor, so take this with that I have a little bit of knowledge of this, is just after being on a ventilator for a long time can actually cause some permanent damage to the lungs. And we thought that he probably had scarring, he was real clear that if he couldn't be active and he was going to be relegated to oxygen for the rest of his life, it was real clear that that is not what he would want, which at least gave us as the children confidence in the decision we made. But I think we're still too early to know what proportion of patients will have long-term side effects. But we do know when patients are on ventilators for other reasons before COVID that can happen. So that is one. The second issue is a lot of people will get very debilitated and then take a long time. Many of us have probably seen news reports or pictures of people that have lost lots and lots of weight. I lost 25 pounds. I was lucky enough to pop up and have enough strength that I did not have to do rehab. But a lot of folks have to do rehab. And that, Catherine, is where one of the things that we're thinking about as we move this back. I'm going to keep bringing it back to blood clots every once in a while, because that was the organizations that Catherine and I are involved in, is blood clots. But we know laying around and being weak and not moving a lot is another reason for this. And we know particularly in this disease, there's something about this disease that causes a lot more blood clots than other similar diseases of this severity. So we think that we may have to do, and there's guidance on what to do when patients have to go to rehab after this particular disease to try to prevent a blood clot. And then we're hearing about to a much smaller extent, but still more than usual from a blood clot standpoint, some heart attacks and some strokes. And we're now starting to see some patients that are getting actually maybe even possibly the virus. Don't know for sure yet, but at least I don't know, maybe affecting the brain in particular. Certainly my father had that. He never woke up from the first time he was on a ventilator, came off several times, even when he was off. This was a 5-6 week saga for him. He never was able to make eye contact through the iPads and stuff with us. So I'm not quite sure what was going on and how his brain was affected, but he lost connectivity with him, which is really, really a horrible part of this disease.
Yeah, absolutely. So some questions have come in, and it looks like people did their research on you and your story. And somebody said that they read you were part of a study and that you received the plasma of a COVID patient.
I did.
And if you had any comments about that.
Yeah, so we don't have it because I take care of COVID patients now, and so I'm keeping up on this to do my doctoring. It's not just because I receive these treatments. We still don't know if plasma works. There's a couple of large studies, one in particular that I'm most familiar with in the United Kingdom looking at this. So we'll see. I think we have enough information that we think that it's fairly safe because we've been giving plasma for other reasons for a long time. So we have a good feel on that. Whether it actually works or not, we don't know. A lot of folks have asked me, what do I think worked? And right after I recovered, my pat answer was one, some, or none. I'm not sure. I think we now know just recently, actually within the last week or two, within the last month, we've seen that remdesivir we think works a little bit, and I received everything. And we also think that steroids, particularly early steroids, particularly with the steroid trial, patients that are on a mechanical ventilator like I was, works quite dramatically in our best study to date. And there'll be more and more trials and studies, and we'll keep learning about we do that. I think right now, today, and I think, Catherine, as you said, what I say today may be wrong and out of date. I don't know, by 10 o'clock tonight. So, is that I got hydroxychloroquine when we first started. We were doing that quite routinely. We're not doing that routinely currently in my hospital, but I was in March. We're not now in June and July is a routine thing. So I don't know. that at least 2 of the therapies that I got have been shown now in published trials to have some benefit.
Wow. So we had a question from a patient in New York City who actually had COVID back in March. They also had a DVT PE 5 years ago, and they were really anxious when they heard about the virus-related clots. Luckily, they made a full recovery at home, and they're just kind of wondering why some people seem to be more susceptible to clotting than others, especially, you know, she has a history of blood clots. So, you know, why did she get through this relatively unscathed?
Right. So my CAT answer for most COVID questions is we don't know. But for that audience member, if you figure it out, please call me. And then in a couple of years, we can go to Stockholm and get a little prize from the Nobel Committee. So
there you go.
There is a lot of research ongoing with that right now. And the hottest topic right now that I see is whether we should give patients full dose blood thinners as soon as they come into the hospital to try to prevent these clots from happening. So it's very fascinating. What we're starting to know, and this may be wrong in days, weeks, or months from now, but one of the current thoughts is this isn't a usual blood clot in the legs or breaks off from the legs and goes to the lungs. This might be small clots in the very tiny blood vessels that are forming in the actually in the blood vessels of the lungs. That might be where that is, which is a different disease than what we call a pulmonary embolism. So to help everybody with a thrombosis, deep vein thrombosis, DVT, is a clot that forms in the vein. When it breaks and moves, and a DVT in the leg breaks off, moves, goes through the right part of the heart, out to the blood vessel, the artery in the lungs, and stops that up so you can't send blood through the lung to get oxygen to send to the rest of the body. When it breaks and moves, it's called an embolism. We now think that what we might have is pulmonary thrombosis, clots in the vessel, not that they broke off and came from someplace else, but they're forming right there. And so whether we can prevent that with higher doses of blood thinners is there are at least 9 trials that have either started or are starting, and we will start participating in one of those trials here within a couple of weeks.
So this is a follow-up question from the same patient who had COVID. They're wondering, is there any danger to giving plasma if they've had a prior PE DVT? I believe they're just on aspirin, so they're not taking any blood thinners.
Yeah, so your plasma center that you donate for will have a bunch of criteria, and they will screen for a bunch of other viruses, frankly, like HIV and hepatitis, etc., that we always do when you donate plasma or blood and stuff. But they'll be able to answer that question. I don't know. I'll be donating plasma probably next week to go back to those viruses. I had to wait for 3 months because I got plasma, and I have to make sure that my donor, even though they were screened, might not have had a disease that was then going to just get passed through me and then go to a recipient for my plasma. So that's why I'm waiting a little longer. But I think I would encourage that because if the plasma trials show benefit, then we're going to want lots available. And if they don't show benefit, then we throw it away. And right now, I'm willing to, I'm going to step up and do it and hope for the best. And if that doesn't work, then oh well.
Yeah. Well, that's all we can do right now, right? I mean, is this just the best that we can?
But I probably have a similar story to the person that's asking the question. I've had a pulmonary embolism, and I've already talked to, because I know the doctors that are doing the plasma stuff, and that's not going to preclude me from donating.
Okay. Okay. Good to know. So one other question about your story in particular, and then we can kind of move on to some more general COVID-19 and clots questions. But is there anything that you can tell us that either isn't out there about COVID from your experience, or that's really misunderstood about this disease, having been through it both as a patient and a provider?
Well, I should have brought a soapbox into my den and stand up on this. Okay, so masks do not increase your CO2 level so you can't breathe. It's a misconception because otherwise surgeons would be passing out for the last several hundred years. So that makes no sense. Okay. Okay. Just because you're outside doesn't mean that you can't spread this. You should be wearing a mask outside unless you're at least 6 or more feet away from each other. Okay. And you should wear a mask. You should wear a mask. You should wear a mask. And after that, you should wear a mask. I'll get off my soapbox.
No, I completely agree, and that's an important message that can't be said enough.
If you said if there's something that isn't known, I still think there's a whole bunch of people that don't know that masks are protective. And remember, you are not protecting, well, you're protecting yourself a little bit because I wear one when I go into a patient's room. Because remember, every patient I see could be asymptomatic and could have this. In fact, we are asking our patients that can to wear a mask also. Patients are wearing a mask, and I'm wearing a mask. When I went and saw patients today, both of us had masks on. So, but when you wear a mask, you are mostly protecting others, and you're protecting yourself a little bit.
Yeah. Yeah. So wear a mask.
Yes.
So far and away, the most common question that we've gotten for this evening is about factor 5 and COVID. And what can you tell us about that in terms of your risk for poor outcomes? Are you at a higher risk for getting COVID? Do they need to be aware of this when you're admitted to the hospital for COVID? Do they test for it when you're admitted to the hospital? Any question you can imagine about factor 5 we've received. So I think there's a lot of anxiety and interest in this space from patients.
Yeah, so be careful a little bit here, but let's do a little bit of, since we've gotten so many questions, tell you at least my take on factor 5 Ligand. So first of all, lots of folks when they have, and so most of the people that are asking this question have probably had what we call a non-provoked or idiopathic clot. It wasn't from surgery, it wasn't from birth control pills after a pregnancy, after having a leg in a cast, or having cancer. So you were tested, and then someone found that you had factor 5 Leiden, and then maybe you are a family member of someone had that, and then you got tested. So it's very curious with the most common type of factor 5 Leiden, which we'll call heterozygous. So you got it from one parent, but not the other. The homozygous, where you got the gene for factor 5 from both parents, is actually quite rare, because you had to find two people that didn't know they had it and have a child together. So we're going to talk, this is geared at heterozygous factor 5 Leiden. About 5% of folks from European descent in the United States, about half that number for folks that have a African descent. So with that, if you have factor 5 Leiden, you are a little bit more likely to develop a clot, but it is not very predictive if you'll get another clot. My guess is where most people know about this. They got a clot, they got tested, they were told they had factor 5 Leiden, and now they're worried. We actually, many folks, including the folks at the University of Leiden in the Netherlands, don't test this very often for patients that have a clot all by themselves, because it is not very predictive of whether you're going to get another clot. It's much more powerful to know if the clot happened all by itself, okay, as we just described. And then the other thing that folks say is, I have patients now and I tease them and they say, well, I want to do a genetic test. I want to find out if I'm at risk for getting another clot. This is when you get the clot all by yourself, things that we call unprovoked clots. And I say, great. And what we're going to do is that we'll do the genetic test that we'll do is to see if you have a Y chromosome. But I can kind of figure that out because I kind of know if my patients are male or female. Because men have about twice the rate of clots than females do. And that is much more powerful. And then some other signs of the blood clots in the legs and stuff, and there's some scoring system. But we don't put factor V ligand into that calculation anymore. We did a long time ago, but we don't do that much anymore. I've only just tested one patient in my career for factor V ligand. And that's just because the patient walked in the door and insisted on it. We had a long conversation about what it could tell us. The virus is too new for us to be able to say whether it will increase the risk. But we know it with COVID, but we do know that overall patients with factor V ligand have a little bit increased risk of having this. But if my patient gets admitted to the hospital with COVID, factor V ligand does not factor in at all in my decision making on what I'm going to give them to prevent blood clots.
Interesting. Huh. Okay. So that's reassuring, I guess, that the data we have on factor V outside of COVID is that it shouldn't, have too much of a bearing, hopefully, on your outcome with COVID.
Yes.
And that it certainly wouldn't alter the course of treatment in most cases. So, okay, great. So does having a history of clots, so taking out the factor V, a person that's had a blood clot, how are they at a higher risk for poor outcomes from COVID, or is it easier for them to get COVID?
So I know of no relationship between having a clot and the propensity to catch the virus or the virus to go from asymptomatic, moderate, severe, or life-threatening. Mm-hmm. We do know that once a patient has had a blood clot, okay, so now I fall into that camp, is that I'm more likely to get a blood clot in the future, okay? That is a very powerful in virtually all diseases. So a patient that's had a previous blood clot, if they're going for surgery, they're higher risk than someone that hasn't had a previous blood clot. If they get sick and go into the ICU, they do that. If they have that if they get pregnant, if they're on birth control pills, once you've had a blood clot, you're at higher risk for getting another blood clot. So what we always do with patients that have had a previous blood clot is that we step up our game and our diligence when we decide on what to do, okay? So for me, for the rest of my life, every time I get admitted or I have surgery, I'm going to tell folks that. And if we're right on the border with the guidelines, say, well, we could give you a little bit or a lot of prophylaxis, or we could give you no prophylaxis or some prophylaxis, this tips us to be a more aggressive approach, as long as the bleeding risk is acceptable.
Now, in terms of managing patients for COVID who are on an anticoagulant, is there any new research out there about Warfarin versus the NOACs, one being more effective than the others, or I guess heparin too? I've heard a lot of, use with heparin. So can you speak to kind of the differences between those?
Yes. So if a patient's in the hospital right now, we're mostly sticking with heparin or low molecular weight heparin, just because there's lots of moving parts and we don't know if the patient's going to get worse or not, etc. So we're sticking with that. And those, and particularly heparin goes away a little faster, and we're actually doing low molecular weight heparin because that's one shot a day versus old-fashioned, what we call fractionated heparin, which is 3 shots a day. If anything, it's 2 more times and a nurse doesn't have to go in and get exposed. Remember, once you have COVID, every time someone walks into your room, they're risking their life to save your life. When I was in the ICU, once I was off the ventilator and I could say thank you. Once I was awake and I could say thank you. Every time someone came into my room, they risked their life to save my life, and they clearly saved my life. So we will do primarily once a day low molecular weight heparin in the hospital. From a treatment standpoint, right now, we don't think that there's any differences. So the newer, what we call the direct oral anticoagulants, are preferred in blood clots because we've already done those 6 trials about a decade ago and forward, pre-COVID, and we know that they cause less bleeding than warfarin. So that's our standard right now. Right now, most folks are treating this as a blood clot and not factoring the COVID thing. So when I left the hospital, I'm on a direct oral anticoagulant because that's sort of the standard treatment for a pulmonary embolism that we would do anyways. The other than fascinating thing with warfarin right now is that with warfarin, since you have to go in and get blood tests, we have found in our blood thinner clinic, a lot of patients don't want to go in and get potentially exposed and go in and get their lab drawn. So that's another added benefit. In fact, we have and others have, and Catherine mentioned the anticoagulation forum, we actually did a whole webinar on that, on how to mitigate warfarin, and one of our, and the blood tests to cut down on those. And one of the things that we suggested also is that we switch patients, if they can, to a direct oral anticoagulant. Again, depends on the copay and the affordability and some other issues, if we can, just so they don't have to go through that exposure risk.
Yeah, and that's something we've gotten a lot of questions about too, is who is a good candidate for switching from warfarin to a DOAC so they don't have to do, you know, the INR testing anymore.
Well, wonderful. Now you're asking me doctoring stuff. I like this stuff. So first of all, virtually all guidelines now will say 2 things. For patients that have non-valvular atrial fibrillation, so they have atrial fibrillation and they're on warfarin, Coumadin, the preferred is to be on a direct oral anticoagulant. Okay, there is overall, when we look at all those together, all 4 of the molecules together, there's less bleeding and they tend towards a little less stroke. So they are preferred right now. So they're the best. Now, the copays, some patients with liver and kidney disease, some other bleeding tendencies will factor into that. But my starting point always with a patient with atrial fibrillation is a direct oral anticoagulant, a DOAC first, and warfarin second. Okay. The same holds true for a blood clot in the legs and the lungs. It's the same thing. So it's always the starting point. Mm-hmm. So now we went and we tried to change a bunch of, we helped facilitate and educate many of our patients, particularly the ones that were calling up when the nurses and pharmacists would call them. They'd say, no, I'm just not going to get exposed. I don't want to go in and get my blood tested. Then we would help guide them and walk them through. And for many folks, they had to then make a financial decision. So, because the copays are always virtually always more expensive for a DOAC than warfarin. Warfarin is very, very inexpensive. Is that what? And then they had to go through that cost thing. My preference is to have most patients on it. There's some patients that aren't candidate, but most are. Mm-hmm. So I hope that answered.
Repeat that last 15 seconds. You dropped out a bit there.
Okay, well, I'm just saying, so the preferred drug for atrial fibrillation and blood clots in the legs and the lungs is a direct oral anticoagulant. And then there are some for a minority of patients, they can't be on it for other particular reasons of the direct oral anticoagulants, but most patients can. So it's always my starting.
Okay, great. So this question's interesting. It says clotting disorders are not listed on the CDC's website as one of the at-risk conditions. But considering that the virus is triggering clotting in infected individuals, should it be included?
So I don't know exactly what spot of the CDC website, but when you say at-risk conditions, my guess is that I don't know anything that says that if you've had a blood clot, it puts you at more risk of either getting the virus or getting really sick from the virus or dying from the virus, which is a different thing than what are the major complications of the virus. Obviously the lungs, I think everybody knows that. But then blood clots are probably second after that for complications from this disease. Now I want to be very careful because when I say this disease, we're still not sure, is it something about the virus and how it affects the blood vessels that causes the clots? Or is it just the patients can get so sick and so much inflammation from the body's response to the virus? Because we clearly know that getting lots of inflammation is a risk factor for getting clots. So we really don't know if it's the virus. So I always say, is it SARS-CoV-2 virus, or is it the disease COVID-19? And we don't have it. I don't think that we know.
Yeah. Like so many things with this. Do you recommend that individuals with clotting disorders isolate themselves to a more extreme level?
No.
Okay, but they should wear a mask.
And in September, get a flu shot.
Get a flu shot, yes. Absolutely. Okay, just seeing what else we have with the...
While you're looking for a minute, let me get another soapbox out here for just a moment and talk about
please.
Flu shot. There's two reasons to get a flu shot. A, because you should, because flu is no fun. But what we have no idea is that what happens if you get the flu and COVID. To me, in October is what I'm very worried about as a doctor that will take care of patients. What if you get both viruses? I'm really scared about that. The other thing, though, is that there are still lots and lots of folks that die every year from influenza. And lots of those folks end up on mechanical ventilators and in intensive care units. And we did not run out of ICU beds or ventilators. We were pretty close in my hospital, pretty darn close. And there are hospitals that are running out right now. And there's some hospitals in LA, in Florida, and in Arizona right now that are flat out of ICU beds. So let's not clog up the ICU beds with influenza because we didn't want to get a shot and then have folks dying from either influenza or COVID, or for that matter, car accident, emergency surgery. I need a ventilator. We filled up all the ventilators with two viruses.
Yeah, I think that's something that I know I tend to forget sometimes, that COVID isn't the only disease still out there. So, you know, all these other patients need to be treated too, and some of them very urgently. So kind of speaking to that, can you kind of talk to patients and going to things like the dentist, to routine care appointments, any suggestions you have for how to stay safe at those, or should you be rescheduling those right now?
Yeah, so I think lots and lots of folks, I'll talk not from the dental practice, but I was a primary care doctor for a couple of dozen years, so I'll wear that old hat. I think almost everybody, frankly, in the world that can, and certainly in the United States, has gone to video visits. So I know now, person that used to run the clinic that I worked in for many years, and a dear friend. I actually saw him earlier today, and we were chit-chatting. And what he's doing is he's sort of hopscotching his visits now that we're out of the surgery. I saw you 3, 4, 5 months ago. We're just in for a regular checkup. We're doing that by video, and maybe then we'll do the next one in person, bounce around, depending on how sick the patient is. But for me, with my primary care doctor, I buy a blood pressure cuff and sort of take my own temperature and my blood pressure and talk to my doctor on the phone and go that way. And it's frankly easier for me also. I only have to run upstairs to go see my doctor when I'm working in the hospital. So that's still pretty easy for me. So I think we'll be doing more and more of that. And I think my prediction is patients are going to get used to this and just say, boy, this is a lot more convenient. Lots of people have to take a day off of work to go see the doctor. I can do a lunch break and see the doctor.
And I know a lot of our board members too have been doing a lot of virtual visits, and they were really, skeptical going into this, and have been pleasantly surprised at how effective those have been for patients.
That's been our experience when I talk to my primary care and specialty colleagues, and I've done a bunch of some virtual visits. I also work in the preoperative clinic, making sure that safer patients go to surgery, and that's where I've done that work. But yeah, I think so.
Mm-hmm. Yeah. So if we can shift a little bit to talking about COVID and blood clots, just talking about blood clots.
Yes.
So, obviously there's a lot of press right now about new treatments and vaccines for COVID, but what's on the horizon for new treatments and medications for blood clots? Is there anything that, is exciting to you or that you think is really promising?
Yes. Okay. So there are a series of clotting factors. Okay. Heparin works on mostly clotting factor 2 and 10. Warfarin works on 2, 7, 9, and 10. Some of the direct oral anticoagulants work on factor 2, others on factor 10, actually 2A and 10A. But the new kid on the block that's in development, that is still years away, is an 11A inhibitor. So yet working on another one of the clotting proteins. And what we know is that some folks in a rare disease where folks genetically don't have 11A, or when we can take 11A out of the mix in experimental animals, those folks don't tend to bleed very much. So even though they don't have that, because many times on the opposite end of the clotting disorders is hemophilia. So for boys that don't have factor 8 or folks that don't have factor 9, that causes bleeding. When you're low in factor 11, you don't tend to have that much bleeding. So the hope is if we can inhibit that, and so you don't make a clot, and we already have some evidence that if you don't have it, you don't bleed, maybe we would have even a safer drug. So that's sort of the hot thing that's right now, and that's sort of a very high level thought process on why we're looking at that moment.
Mm-hmm. Very cool. And what phase is that in? Is that in clinical trials yet, or is that still?
I think it's just working through phase 2, and then if promising, they'll go into phase 3, and then phase 3 is usually a couple of years.
Yeah.
Right.
Okay.
And because we have alternatives, I don't think we'll be putting our foot on the gas like we are with COVID because we don't have an alternative. So,
right.
And I just say that because people are saying, well, how come we can push the COVID stuff? Well, part of that is because many governments are also throwing billions and billions of dollars at supporting those efforts.
Do you think that, the kind of fast speed that they're moving through with these vaccine trials, do you think this is going to alter the landscape of clinical trials in the future?
I think what we'll learn is that we'll probably build platforms to do this. What's been incredibly impressive, however, is just the work that's done. So in the New England Journal of Medicine, here, I think it's this week's or last week's, we have the steroid study that came out of the United Kingdom. And I think in that paper they say we went from 100 days from the first draft of the research paper to publishing the results that show that we can save lives in patients, particularly on mechanical ventilation, with a cheap, widely available drug. That's pretty cool as a scientist to see that. But there was also huge need to do that. But what you will get with the speed, I'm not being critical at all, but you have to cut some corners. Mm-hmm. I think where we are with the pandemic, that's okay. That's reasonable to cut those corners. But with developing a new blood thinner, there is not the overwhelming need to cut the corners, so we won't cut those.
Yeah, that makes a lot of sense. So speaking of treatments, with the DOACs, we had a couple questions about side effects with those. Have you ever heard of increased anxiety from patients taking a DOAC?
No.
No. Okay, good to know. What about skin rashes?
I think I've heard of it rarely. If it is, it's reported quite rarely. And what's I've always been interested is that when a patient gets a rash, is it from the drug or is it the coloring that we use for the tablet? Oh, we know people can get allergies to food coloring and stuff, and sometimes it might be the dye.
Oh, wow. Is there the option to get, if you know you have an allergy to dye, is there an option to get medications that aren't coated in that or not?
I don't know, but what I practically do, because we have several DOACs, if I had a patient that took this and we were worried about a skin rash, I would just change because the next drug is also a different color, so likely it won't have the same dye.
Okay. And is there any research that's been out? I know DOACs haven't been out for that long yet, but about any long-term effects from taking DOACs?
No, we haven't, and they've actually been out for over 10 years now. So we do have we have long-term experience with that, and I haven't seen any of that. There's a recent study that talked about thinning of the bones a little bit. We've known that for a long time that can happen with warfarin. I just saw a study, and again, I just read the abstract. I'm trying to keep up with my clotting stuff, but I have to keep up with my COVID stuff because I'm taking care of those patients right now. It suggested maybe that there was a less side effect. That's a common sort of long-term non-bleeding side effect that we've known about with warfarin, like maybe a little less of that with a DOAC.
Mm-hmm. Mm-hmm. So how has your expertise in anticoagulation and all things blood clots helped you treat COVID patients?
Well, we tried to push out. So what we did, we saw that we knew the blood clots were happening a lot more. So as you mentioned, I serve as a board member of the Anticoagulation Forum. So what we wanted to do is put out some guidance, and there's 8-9 different organizations at least that have put out guidance in and around this area. But we wanted to do that, but we actually did a webinar, and we were planning that webinar on this issue. And I can remember I didn't say much because I was in the ICU on a mask, non-rebreather, I could only get about 4 or 5 words out at a time. Colleagues now tell me that was one of their favorite meetings I was ever on because I never dominated the conversation. But we did that. We planned the webinar. It was given the next week. I didn't participate because I was face down on a ventilator that day. And then when I woke up and got off, the team had worked so fast, we turned that into a paper. I actually was reviewing the paper and editing it while I was still in the intensive care unit. And by the time I was home for a week, it was published. So we got that out there. And what we actually said in that, we just tried to give some guidance about what we should do when you get into the hospital. And all of the guidelines recommend that you should get standard, at least what we call prophylactic doses with a low molecular weight heparin. So one that's most commonly used in the United States is enoxaparin or Lovenox, but there are a couple others also. Then there is diverging. I won't say disagreement because we don't have the research to tell us what the right answer is, but there's differencing of opinion on whether we should up the amount that we give in a patient in the intensive care unit. I did that. We upped it when I was in the ICU. And then most folks are probably saying, don't go on full dose blood thinners right now to prevent a clot, okay? But encourage patients and investigators to enroll in a clinical trial that's doing that. And I hope to be doing that in my hospital by end of month.
Wow. Wow, it really is remarkable how quickly things are moving forward with that, and people are coming together to, try and do what they can to help fight this. So we've got about a minute left, and I always like to give our expert the final word. So if you want to get back on your soapbox for a little bit, what are your words of wisdom for the group this evening?
Yep. So 5 points of advice. Number 1, wear a mask. Number 2, wear a mask. Number 3, get a flu shot. Number 4, get a flu shot. Number 5, wear a mask.
There you go. Well, I think those are all really easy and really, effective ways to help fight this. So thank you so much, Dr. Kaatz, for your time this evening. It was, really great seeing you, even though it's not in person, but virtually, and hearing your story and what a remarkable recovery you've made. And again, I'm sorry to hear about your father, and that you're back in the hospital treating COVID patients again. I mean, what a testament to, what a terrific healthcare provider you are. So thank you for all your work in that, and all your past support of NATF. So we really appreciate everything that you do.
Okay, thanks, Catherine. Good night, everyone.
All right, good night, everyone. Thank you so much. Take care.